practical pediatric endocrinology course is actually something which has been quite close to Grow Society, and we've been doing that for quite some time. We actually started off initially with the programs which were there in terms of the initial workshops, which started way back in 2010. We conducted around workshops across the country. In 2011, we had the first practical pediatric endocrine course, and Dr. Raghupati, Dr. Chaurasia, and Dr. Rashmi Kapoor, all three of them were part of that inaugural program as well. Subsequent to that, we realized that doing programs at the level of individual places, we started doing PPECs across the country, was very labor intense and was very difficult to manage, and a lot of logistic issues. So we thought of using the social media, the YouTube and the Facebook platform to spread knowledge about pediatric endocrinology. And from there, we realized that while videos are going to help out, we need something more concrete in terms of more information which is available. We started with the round fellowship programs, but how many fellows can you accommodate? 2 or 4 in a given time. If you want more people to learn, the best way was to go online. And in 2018, 3 years ago exactly, on this very date, we started MedEClasses, which is a learning platform, and this is really evolved now with multiple other factors happening in the form of books and mobile application to make it much easy in terms of overall aspects. So over the last 11 years or so, we have conducted multiple programs across the country. Over 10 PPECs have been conducted. There have been over approximately 8 modules which have been involved and implemented in around 100 workshops across the country. So a lot of people have interacted and really find friends across the country in that regard, which has been really helpful in that perspective. So as discussed, we started off with our online learning program. And this e-learning started off with the number of videos which are now available over the YouTube. And on last count, there have been 700,000 views from those videos, watch time of around 40,000 hours. So there's a huge amount of pediatric endocrine repository which is available, which is being accessed across the world. But as I discussed, that this is more like a non-systematic way. We therefore went ahead and started with our learning.growsociety.in to provide pediatric endocrine learning using validated tools and practical assessment. And we have got multiple courses. Till now, we are on 24 courses available. We've got special courses for postgraduates and fellows, providing specific needs using animated videos, lectures, and other information. We also conduct bi-weekly grand rounds. So every month we have got one for the postgraduates and one for the fellows. So it's free over Zoom. All of us should join. We already have around 700 people who are regular join these programs. And this is quite helpful from that perspective. As Sir was talking about, we had this basic pediatric endocrinology, and just recently, 3 months ago, we launched our advanced pediatric endocrinology, which is a 2-volume book related to every aspect of pediatric endocrinology. So entire course content is in these 1,000 pages, which are there in these 3 books. So these 1,000 pages, they are all online, as well as now we already made it offline as well, available for people. We always realize that the best way to practice is not really going through books, but to actually go from patient to the book and back. And therefore, we started developing these applications which make life much easier. So rather than going back and reading about DSD, you start off from the patient's point and then use that application approach pathway. So now the endocrinology app is by far the most resourceful endocrinology app on the web and the most downloaded one as well. It has got over 50 pathways, management, approach pathways, analytic tools. And over the next month, we're going to make a massive change in that, adding many new interpreters like puberty, DSD. So if you just put 4 inputs, you will get an output of DSD, output for puberty and obesity. I'm in pediatric endocrinology. This is a complete 3-year program, which is actually a hybrid program of both on-site and online over 4 weeks of visit, as well as online, as well as a diploma course in pediatric endocrinology for people who have got lesser times. So when we say DSD or disorder of sexual differentiation, we are talking about a discordance between the genetic, gonadal, and phenotypic expression of that particular individual. So there can be various variations which may happen. From a clinical perspective, we can divide DSD into XX DSD, which essentially means that this is an act of commission. Every individual who doesn't have any hormones, who doesn't have any estrogen, doesn't have any estrogen receptor, no testosterone receptor, will have a default development towards the female as perspective. So for an XX individual to develop DSD, you need to have something active, which is there. And that could be in the form of either you've got androgen excess, which is coming mostly from the adrenals, or from the ovaries because of the aromatase problems. 95% of cases would, I will say, 21 hydroxylase deficiency. So if you have a XX DSD, it is a life-threatening condition. Exclude 21 hydroxylase deficiency immediately. How would you know that? Just look at, you will have no gonads and you will have a Mullerian structure. When we'll talk about DSD, as we talked about puberty, you said you look at breast and pubic hair. Here you're looking at gonad and Mullerian structure. So no gonad, Mullerian structure present, it is XX DSD even before your karyotype comes in. In this situation, think of CAH. Others are very rare, gonadogenesis and aromatase deficiency. And aromatase deficiency should be considered if you have maternal virilization. The mother gives a history that there was acne, there was hair growth, and maybe clitoromegaly during pregnancy, which went off. So this is for XX DSD. The most complicated ones are XY DSD. And as I said, XY DSD is an act of omission. Something has went wrong. Your gonads did not develop, testes did not develop, testosterone was not formed, dihydrotestosterone was not formed, or there was no action. This is a more complicated picture, a much wider presentation. The classical clinical picture which we'll see in XY DSD will be gonads are present, but you don't have any Mullerian structure. So again, 2x2 table, look at gonad, Mullerian structure, you will get the diagnosis. XY DSD can be because of problems in gonadal development, in which you have to look for kidneys, adrenals, and other factors as well, or impaired production of hormones, which may be associated with an adrenal problem as well. So you may have salt wasting in proximal defects, you may have hypertension in specifically 17-hydroxylase situation, or you can have isolated testosterone deficiency. Then you have complicated picture in which you've got both Mullerian structure and gonad, and this is something tricky. So what we'll do over the next half an hour or so is to go through a lot of cases which will really good in that perspective. Before that, we need to know what really is DSD. So anybody with atypical genitalia is DSD, but if you have bilateral cryptorchidism, that's a dangerous sign. That could be a sign of salt wasting 21 hydroxylase deficiency in an XX individual, and the child will die if you don't treat. Penoscrotal hypospadias, yes. Any phenotypic male with bilateral cryptorchidism and severe hypospadia requires evaluation. Any phenotypic female who has got inguinal gonads, be it in the newborn period or be it later on, also requires evaluation in that perspective, and that becomes absolutely important from that regards and understanding in that situation. Now, again, just a 2x2 table. If you have got just the Mullerian structure, no gonad, this is XX DSD. If you have got just gonad, no Mullerian structure, this is XY DSD. If you've got both, you're talking about a AMH problem or a ovotesticular DSD. And if you've got none, it means that gonad was there. Maybe now it is abdominal, or it is gone. It may be amenorrhea. So this, I think, is the fundamental aspect, which is very, very important from that perspective. And this is how you can proceed from there in that perspective. So we'll start off now with the first case. Dr. Manoj, please come up and start the part.
We have 14-year-old preterm girl come by concern with atypical genitalia. On examination, picture showing like this. So, Dr. Volna, what will you advise for this patient?
So this child has presented with complaint of clitoromegaly, but she does not appear to have any labial fusion. And does she have any palpable gonads?
No.
No palpable.
So there are no palpable gonads. There is no labial fusion. What is the size of the clitoromegaly?
It is less than 0.9.
So anything that is less than 1 centimeter does not really need workup. It is just a physiological variant. We can just reassure the parents and leave it there. So prominent clitoris is not something very significant, does not need workup.
We have second case, a 3-month-old girl having no vaginal opening, no clitoromegaly, no palpable gonads. Parents came with that concern of this kind of genitalia. What you will advise, Dr. Purnima?
So this looks like a phenotypic female, and with a, can I get the picture, please?
Oh, no. relax.
So phenotypic female with the clitoris, which appears normal, and there's a single opening. So what I could notice is there's a structural abnormality. So and no evidence of palpable gonad as per the picture.
No palpable gonads.
Yeah. So the structural abnormality, probably it could be a labial adhesion, and vaginal opening is probably obscured because of the structural abnormality. So
what will be the take-home message for this patient?
Yeah. So most important point is clitoromegaly is very important to proceed for the DSD evaluation. And labial adhesion per se doesn't require any workup to be done and no intervention, as Dr. Yutika had mentioned earlier in her earlier talk, like it appears around 12 to 24 months of age due to low estrogen deficiency. Unless there are symptoms of UTI or recurrent UTI, then requires an intervention for the labial adhesion.
I think the big message very clearly which Dr. Purnima has given is that if you're thinking of a labioscrotal fusion, clitoromegaly is essential. You can have clitoromegaly without labioscrotal fusion. You cannot have labioscrotal fusion without clitoromegaly. That is a big message which is there. So this is labial adhesion and not really a DSD.
We have another patient, a patient referred from Pediatrician, a 2-month-old boy having this kind of genitalia. Parents concerned about the DSD and patient having penile hypospadiasis. We did stretch penile length that was 2.8 centimeter. Patient having palpable gonad will well from scrotum and there is gonad is present. So Dr. Neha, what you will advise for this patient?
Thank you, Dr. Manoj, for the inputs, and you have already examined the case well. So as we have seen in the previous 2 cases, like isolated clitoromegaly and labial adhesion, this case is also not a case of DSD. So a careful evaluation of the stretched phallic length and the gonads help us rule out the cases of DSD and prevent the child and the family for unrequired stress and investigations. So this child does not need any workup. And coincidentally, I encountered a similar case in OPD today, which was referred from the surgery department. So these are one of the most common cases which are referred to us. So child visited the surgery department for this hypospadias, and from there, child was labeled as DSD and was referred to our OPD today. So one needs to be aware of the normal variants as well.
Okay.
Thank you.
We have another case, a 8-year-old boy referred for the small phallic size. Examination showing boy is obese, height is 130 centimeter and weight is 44 kg. So boy having obesity with testicular volume is 2 ml. Dr. Sajili, what you will advise for this patient? Either it is DSD or not.
So thank you, Manoj, for the update. So this case, he is the obese child, but before labeling the phallus as small, we need to measure it. Okay, so what was the stretch penile length in this child? Can you elaborate on that?
SPL was done, that was 6 centimeter, and patient having no any polydactyly or no any syndromic features.
Yes. So one important thing is in patients with obesity, most of the time the penis is buried because of the peripubic fat. So one needs to measure the SPL, and only after seeing that how much is the stretched penile length, we can label it as small phallus. Sometimes obesity can be associated with small phallus in some syndromic conditions like Bardet-Biedl or Prader-Willi syndrome. But before labeling it as small phallus, one should always measure the stretched penile length. And I would say that is the more important message from this patient case, that we don't need to work up any child before measuring the stretched penile length.
So what will be your key message?
So yes. So in this patient, any patient who presents with obesity and a small looking phallus or a small looking penis, one should first measure the stretched penile length, because buried penis is the most common presentation in obesity.
I think that's very, very important. In the first 4 cases were very essential to understand that we should not evaluate everybody. If you just have a prominent clitoris, if you have got labial adhesion, if you've got penile hypospadia, if you've got micropenis, it is not DSD. Do not waste your workup, because when you say DSD, your workup becomes too much. You think of karyotype, you think of testosterone, DHT, 17-OHP. So you don't need workup in these cases. Let's go to the real cases who need workup.
We have 3-day-old child. Parents came with concern for the DSD, examination showing this, and patient having no palpable gonads and preterm stage 4. So, what do you think, Dr. Varuna, for this patient?
So this child is a 3 days old child in preterm stage 4 with no gonads, and the Mullerian structures are present. So this is definitely a case of XX DSD. So I would be very concerned with this 3 days old child, as because this child is at very high risk of being a case of 21 hydroxylase deficiency. So I would like to see what is the status of the 17 hydroxy progesterone levels in this child, and also if 17 hydroxy progesterone, apart from that, what is the status of DHES and deoxycorticosterone levels? That is available.
Okay. So in this child, there is no palpable gonads, preterm stage 4 with no gonads, and uterus is present. So it is 46XX. Sodium is low, 120. Potassium is higher side, 6.1 centimeter, and 17-OHP is pretty higher side, 120 nanogram per ml. So
what do you think, Dr. Varuna? Now this case seems to be what you were thinking right from the beginning. Hyponatremia, hyperkalemia, and 17-OHP. What do you? How do you proceed from here?
So this is an absolute medical emergency, because if not picked up in the time, these children can come in shock and sometimes even die undiagnosed. So this child has got definitely, because 17 hydroxyprogesterone levels are also raised, and child has got salt wasting. So this is a case of 21 hydroxylase deficiency, and this child needs to be immediately started on stress dose of hydrocortisone. And once the child has been stabilized, we can gradually shift to lower doses of hydrocortisone at around 10 to 15 mg per meter square per day, along with mineralocorticoids, fluorocortisone, 100 to 200 micrograms per day. And the gender of rearing, so these children, because they have their karyotype is XX, and they have Mullerian structures, they have high chance of having fertility as females. So they should be reared as females, and there may be gender identity issues later on, but as of now, we always prefer them to be raised as females.
And the big message, I think, from here is that if you have a boy, apparent boy with bilateral cryptorchidism, we have seen patients who are missed. They are labeled as boy, and that can come with shock. That's what Dr. Verma is highlighting, very important. And 17-OHP levels, again, should not be done right at birth. Wait for some time, because then they can be falsely high.
So let's move to the another case, a day 3 child having parents concerned about the DSD, and examination showing this kind of genitalia. Patient having no gonads with preterm stage 4. So Dr. Purnima, what you will advise for this patient, and how you will proceed?
So with this picture, what I could say is there is a virilization of the genitalia, wherein the clitoromegaly is into stage 4 of preterm, and there is also scrotalization of the labia. So the next step would be to see what is the clinical clues that I could get for the categorization of the DHD. So if there is any evidence of hyperpigmentation, the likely diagnosis would be congenital adrenal hyperplasia. And among them, the variant of the subset of the CH, if there is evidence of hypertension, then the likelihood will be 11-hydroxydeoxylase as well as 17-alpha hydroxylase deficiency, which is usually seen in a childhood, not in the newborn period. Salt wasting crisis is seen most commonly in 21-hydroxylase deficiency, and also in P450 oxidoreductase deficiency, 3-beta HS3 deficiency, as well as star and side chain cleavage and Smith-Lemli opage. So skeletal dysplasias are predominantly seen in P450 oxidoreductase deficiency as well as SOX9. Mainly the limb deformities as well as joint contractures will be seen in the newborn period. And if there's any evidence of polydactyly and syndactyly, it is more a clue towards a Smith-Lemli opage syndrome. And with these, if we could get a prenatal history of any maternal virilization during the pregnancy, so the diagnosis or the clues would go towards aromatase deficiency and P450 oxidase deficiency, as well as luteoma and the ovarian tumors. So one of the subcategories of the one of the subcategories of the androgen excess. So going back to the algorithm, and this newborn doesn't have, is there a palpable gonads?
No, no gonads.
So there are no palpable gonads. The next step would be to go ahead the ultrasound pelvis and look for the gonads and whether the Mullerian structures were present. So Mullerian structures were present. Then the next step would be to look into the cytogenetic studies, and the cytogenetic studies revealed 46XX. So this tells us, coming into the category of DSD, 46XX DSD, are we looking at gonadal dysgenesis or the congenital adrenal hyperplasia? That is the inadequate, the deficiency in the synthesis of the sex steroids. So the most common is the CH. And among CH, 17-OH progesterone levels to be looked at. The most common condition that we come across is 21-hydroxylase. Being a newborn, difficult to differentiate from 11-beta-hydroxylase, which can also present with salt wasting crisis. So deoxycortisol to be done, and 17-OH is 20 nanogram per ml, which is suggestive of congenital adrenal hyperplasia. The next step, we would like to look if there is any further blockage in the steroidogenic pathway. So maternal virilization gives us a clue for aromatase deficiency. So this is more suggestive of a aromatase deficiency in this newborn. So the key message.
What you will address for gender of rearing in this patient?
So in this baby, gender of rearing would be female.
So what is the take-home message for this patient, Dr. Purnima?
So the take-home message here is the presence of Mullerian structures with no evidence of palpable gonads, as well as cytogenetic studies revealing XX, 46XX, and with the evidence of maternal virilization, which is strongly pointing towards aromatase deficiency, is more a clue. The aromatase maternal virilization gives us a clue that it is due to aromatase deficiency.
I think that was a very, very interesting case. And the reason we brought it here was there was one more finding we have in history, that the penile size did not increase after birth. Because whenever you have CH or something, the phallic size increases. Because of the mini puberty or CH, of course, they will increase. But here there was not increase, which basically meant that as the androgen exposure was less, estrogen production was also, where the estrogen production was less, androgen was also less. And very carefully, when we asked, we got that history of some virilization in the mother, which was not very significant. So again, always go deep in terms of asking for history, because that can avoid unnecessary workup for in the form of steroidogenic, other factors like gonadogenesis or other things.
Let's move to another case. A 14-day-old child. Parents came with the concern regarding the DSD examination showing this kind of genitalia. Patient having bilateral palpable gonad is there, but in USG there is no uterus, and karyotype showing 46XY. What you will think about this patient?
Thank you, Dr. Manoj. So using this case scenario, I will like to again reinforce the importance of examining the gonads and the Mullerian structures in a case of DSD to further classify them into XY or XX DSD. So absence of Mullerian structures with gonads signifies that there was a functioning fetal testis which produced AMH, but there was an inefficient testosterone action. So this could either be due to a defective testosterone production or a final testosterone action. And using a combination of these hormone levels, DHEAS, androstenedione, testosterone, and DHT, we can further localize the level of defect in the adrenal steroidogenesis pathway. For example, if all four are low, then the defect lies higher up in the adrenal steroidogenic pathway, as we can see in the star defect, while if all these are high, then this classifies it into a receptor defect, which is seen in androgen insensitivity syndrome. So using these chemical bioparameters and the clinical pointers, could you please give me the findings of this case further?
There is bilateral.
So as already described by you, there were palpable gonads while the Mullerian structures were absent. So to classify it into whether it was a testosterone production defect or an action defect, we need the testosterone levels. So what were the testosterone levels? So as these were low, it states it could be a testosterone production defect, an isolated testosterone production defect, or a combined adrenal and testosterone hormone production defect. So getting a sodium status in such cases helps differentiate between the two pathways. So as you have already pointed out that there was hyponatremia, then clearly it was an adrenal involvement as well, and not an isolated testicular biosynthetic defect. Further, you have given me the value of 17 OHP, which was moderately high. So on these four, 3-beta HSD is the one which can have a high 17 OHP with low sodium and the clinical picture of this patient.
What you will advise for gender of hearing for this patient?
So gender of hearing should be one thing which should not be done in an emergency. It should always be done after complete evaluation, because the further sexuality and reproductive ability will depend on this. Also, the psychology of the child depends on the hormonal milieu. So for all 46XY DSD, except for androgen insensitivity syndrome, we recommend the gender of hearing to be as males. So from this case, we can again reinforce the message that absent Mullerian structures in presence of a gonad is 46XY DSD. And presence of salt wasting signifies that it is a combined adrenal testosterone biosynthetic defect, along with a 17 OHP, high 17 OHP, which points towards the 3-beta hydroxysteroid pathway. And gender of hearing should be male in this case. Thank you.
Thank you. We have another case. A 14-day-old child came with the concern of the DSD. Examination showing asymmetrical genitalia. A right-sided testis is present, and on USG, uterus is also present. So what do you will think about this patient?
Thank you, Dr. Manoj. This is definitely a case of DSD. If you see, because gonads are present as well as a Mullerian structure is present. If we recollect back, if we see the graph that's described before, if there is a gonad plus uterus, we have to think of two differentials, either a testicular DSD or a Mullerian hormone secretion defect. Okay. So let's go ahead and evaluate this case. So can you just highlight the karyotype of this child?
Yes.
So this karyotype looks like a 46XX. Okay. So this is a 46XX with Mullerian structures present with right gonadal gonads, right-sided gonadal testes, right?
Yes. So I think this was a very important thing to remember, that we actually asked for 50 plates, but this was given as 20 metaphyses only. So this is again a big message probably coming in surgery, that this could be a mosaic typically in that setting, yes, because you have to have some Y line, which was there in this case.
Yes, or it can be an SRY insertion.
Yeah.
So considering the presentation, if you go through the flow chart, we can see that the child had palpable gonads. He had Mullerian structures present. So the two differentials that we had were either AMH synthesis defect or AMH resistance, or a O testicular DSD. But with the clinical picture, the child looks most likely a O testicular DSD and a karyotype of 46XX with a mosaicism. Okay, so the take-home message from this case is that, as sir described previously, if there is a gonad plus a uterus, if it is present, it goes towards a O testicular DSD. The child needs to be evaluated properly. And on examination, if you ever find that the child is having asymmetrical genitalia, it is most commonly suggestive of O testicular DSD.
Let's move to the another case. We have 15-year-old girl presented with a delayed puberty. Patient having inguinal gonad is there with no Mullerian structure. Dr. Varuna, what you will advise for this patient, and how you will proceed for this patient?
So if this child has an inguinal gonad but no Mullerian structure and has not undergone puberty, then we are definitely dealing with an XY DSD, because the inguinal gonad, a palpable gonad, is highly suggestive that it is a testis, and no Mullerian structures confirm that there was a testicular tissue present during the intrauterine period that secreted AMH. So the next step would be to know whether this is a disorder of steroid synthesis or a disorder of steroid action. So now I would like to see what are the testosterone levels and what are the gonadotropin levels in this child.
FSH we did that was 120 and karyotype is 46XY and testosterone is very low, 0.1 nanogram per ml.
So definitely it is a steroid synthesis defect, that is testosterone is not being formed. Now if testosterone is not being formed, I would also like to know what is the status of the other hormones, whether they are being formed or not, and is there, what is the salt structure status of this child, whether she is salt wasting or she is hypertensive. So you've mentioned that this child he has a BP of 150 by 90, which is definitely high for a 15-year-old child, and potassium is also on the lower side. So this child fits into a deficiency, a 17-hydroxylase deficiency.
And what will be the key message for this patient?
So key message is that if you have a XY DSD or a girl with presenting with delayed puberty and hypertension and does not have has very high FSH levels, we should definitely consider a possibility of 17-hydroxylase deficiency. So primary amenorrhea may just be the presentation of DSD in some cases.
Okay, thank you. We have a 12-year-old boy presented with the complaint of the hematuria. On examination, there is no palpable gonad. Dr. Punima, what you will proceed for this patient?
Can I have the algorithm, please?
Yeah.
So this is a 12-year-old boy with hematuria. He doesn't have palpable gonads. So next step, I would like to look at his ultrasound for gonads, and there is presence of uterus. So this is suggestive of androgen excess production. So I would like to look at the hormonal profile, the cytogenetics, and the cytogenetics reveals 46XX. So the clinical examination, the next step which I would like to look at is blood pressure, which is 160 by 110, which is hypertensive, and then the investigations to look for the electrolytes, which helps us to differentiate mainly from other variants of the congenital CAH. Hypokalemia and deoxycortisol is very high. So that is suggestive of 11-hydroxy dehydrogenase deficiency. 11-hydroxylase deficiency. So the gender of rearing for this boy would be male. The reason is he would have definitely had stage 5 Prader staging, where it is complete masculinization of the clitoromegaly. That is the most severe form, and he must have been appeared like a phenotypical male. And the hematuria for this could have been the vaginal bleed. So due to urogenital sinus, presence of the urogenital sinus. So I would suggest for the multidisciplinary approach for this child, for this boy with the pediatric endocrinologist, pediatric surgeon for the genital reconstruction, as well as for the, not for the genital reconstruction, for the urogenital sinus correction, as well as the psychiatrist and the psychologist. Mainly, he will definitely have issues of gender dysphoria as well as the identity.
Thank you very much. A 15-year-old girl presented with the primary amenorrhea. Height is 154 centimeter, weight is 48 centimeter, 48 kg. Breast stage 4 and pubic hair 2 with inguinal gonads. Dr. Neha, how we will proceed for this patient?
So again, coming back to my previous message, in a case of DSD, we have to focus on the two structures, gonads and Mullerian structures. As you have said that there are palpable gonads, could you please tell me about the Mullerian structures, whether they were present or not?
Uterus is absent and karyotyping is 46XY.
So again, as in my previous case, there is gonad, but there is absence of Mullerian structure, which signifies that there was a functional fetal testicular tissue producing AMH, but the testis action was inefficient. So we would like to know whether there was testosterone production defect or an action defect. So as you have pointed out that testosterone level was high, that means it was not able to act on its receptor. Now further, we want to see whether this testosterone was not able to convert into its active metabolite or whether the active metabolite was unable to act on the receptor, for which we like to know the testo-DHT level. So as you have mentioned that these levels were low, So this goes towards a case of complete androgen insensitivity syndrome, which means that testo was able to get converted into its active form, but this active form was not able to act on the receptor, producing a picture of complete androgen insensitivity. So these patients, they develop feminization during puberty. As far as gender of rearing is concerned, all 46XY should be reared as males except for complete androgen insensitivity syndrome patients. So take home message from this case would again be presence of gonads with absent Mullerian structure, think of 46XY DSD. In a case of primary amenorrhea without puberty, think of androgen insensitivity syndrome, and there is a feminization tendency during puberty, and all these children should be reared as females. Thank you.
So let's move to the another case. A 10-year-old girl presented with the complaint of clitoral enlargement. Phallic length was 2.2 centimeter. Patient having bilateral gonad present. Dr. Sajili, what you will advise for this patient and how you will proceed?
Thank you, Dr. Manoj. So let's go with the algorithm. So we know that the child has a bilaterally palpable gonads. So we need to look at the uterine Mullerian structures. So in this case, as per the data, you can see that the uterus is absent and the karyotype is 46XY. So this is a child with a 46XY DSD. Okay. So there is increase in the phallic length at the age of 10 years in a girl who had gonads. This may be because of slight increase during the puberty in patients with 46XY. Okay. So let's do an evaluation. So in this child, if you see the testosterone levels were normal. Okay. So as Dr. Neha described, we need to know whether it is a hormone conversion defect or it is a action defect. So let's see what was the dihydrotestosterone levels. So if you see the dihydrotestosterone levels were low, so it means that the testo is being produced, but it is not getting converted to an active hormone dihydrotestosterone. So this most likely suggests a defect in conversion, which is most commonly 5-alpha reductase 2 deficiency. So in this patients, you can see that in puberty, they may have increase in their phallic length and they may undergo enlargement of the penile length. So if you follow the algorithm, you can come to the diagnosis of 5-alpha reductase 2. And the gender of rearing in this patient is always males because there is virilization that will occur in puberty. Thank you, Dr. Manoj.
Very nice discussion by Dr. Sajili, and very clearly, if you look at two things, we have tried to do all the 12 cases have shown that if you looked at basically the uterus and the Mullerian structure, you would be able to identify the diagnosis immediately, and that will help out.